again, obviously what we're doing this morning, we've outlined the enormity of the issue. We've talked about some good things that have been going on both nationally and regionally, and we want to continue along that vein. I want to introduce to you our panel, and this panel, of course, is devoted to trying to outline the resources that there does exist in our region to reduce the demand for opiates. And again, I mean, I come from law enforcement, obviously, so we're very focused on supply, but we can't simply be focused on supply, as Ms. LaBelle talked about this morning. It's simple economics, and as a student of economics, I know very well that you have to reduce the demand side as well. So we wanted to talk about trends in supply and the positive aspects that we've been able to present on that, but we also need to talk about the reduction of demand. Immediately to my right is Dan Smoot. He's the president and CEO of Operation Unite in Kentucky. Sarah Melton is beside him. She is an associate professor of pharmacy practice at the Gatton College of Pharmacy here at East Tennessee State University, and she is also the director of OneCare of Southwest Virginia, so she crosses the border. Rodney Bragg is Assistant Commissioner of the Tennessee Department of Mental Health and Substance Abuse Services, Division of Substance Abuse Services. Obviously, they're in Tennessee. And Kathy Paxton is Director of the Division on Alcoholism and Drug Abuse for West Virginia's Department of Health and Human Resources, Bureau for Behavioral Health and Health Facilities. Again, I'm Booth Goodwin. I'm the United States Attorney for the Southern District of West Virginia. As you saw on those slides this morning, my district has been affected perhaps more than any other in this terrible plague. We have devoted an enormous amount of resources to attacking the supply, but we need to do just as much about demand. The most alarming trend, I think, we've heard about this morning is the fact that once we do reduce that supply of prescription drugs, then people move on to heroin. And I heard from the mayor of Parkersburg last night. He reached out to me and said, Booth, we just had 3 more overdose deaths just within the last week. And Parkersburg's not a big city. They're seeing firsthand that trend from prescription drugs into heroin. And as we all know, and as that shows, is that the overdose potential with heroin grows exponentially because of the fact you don't know whether you're getting 20% heroin or 80% heroin. You just don't know. And if you get an 80% batch when you're expecting a 20% batch, you die. So obviously, the one thing this move to heroin shows is that there has been a reduction in those prescription drugs through various developments, like aggressive enforcement, like prosecution of pill dealers and pill mills, and the shutting down those pill mills. But part of it is a result of decreased demand for certain brands of prescription opiates that have been reformulated. The chief said on the last panel that he alluded to the fact that there have been a couple different drugs that have been reformulated. And I think that's probably a good way to transition into this panel on reducing demand, because demand for those particular prescription drugs have been reduced. So I want to start with Sarah. Sarah, could you speak to that reformulation, what was involved, and whether you see it expanding to other suppliers, and what the barriers may be for such expansion?
Sure. What he's referring to are the reformulation of several of the long-acting opioid medications, including OxyContin, which is oxycodone, and then Opana extended release, which is oxymorphone. It's been a really interesting phenomenon to watch when Purdue reformulated the old formulation of OxyContin. Within a week to two, the street value when the old formulation was totally gone just plummeted. It was $1 a milligram, and then it's down to really significantly less. And within a very short period of time, patients switched directly over to Opana, which did not have the abuse deterrent formulation. And so then Opana oxymorphone was the drug of choice. You could get the extended release and get the large amounts that once you broke the time release mechanism, you can get the big high all at once. What's interesting now is that with the oxycodone reformulation, the generic formulations were not allowed to be made of that extended release. We don't have generic OxyContin any longer. But we do have immediate release, of course, oxycodone, which has really become the drug of choice, and most people that have oxycodone as the drug they like. Opana, however, the extended release, the generic formulations of that were already approved by the time we had the abuse deterrent formulation. Any of you ever go to the website called Blue Lights? I highly recommend that as a website to go read about all the different mechanisms that people out there are using to try to get around the abuse deterrent formulations. From what I can tell and from what patients tell me, OxyContin still is extremely difficult to manipulate. Opana, not so difficult. They have been able to undo that abuse deterrent formulation. If you look at Virginia's statistics, methadone for a long time was the most lethal drug in Virginia, usually combined with alprazolam, which is Xanax. And then we moved to the oxycodone was the most lethal drug, and now it's morphine. And I think that really is showing the transition from the OxyContin reformulation to the oxymorphone. And the morphine that we had in beta that had the naltrexone core was pulled from the market because of production difficulties. So that's just a little bit of background about what you see, but that surely decreased the demand because the demand for the new reformulation for OxyContin plummeted. And even patients that got switched, they'll say it doesn't work anything like the old ones. I'm sure the pain physicians that are here will attest that patients will say that. Does that answer your question?
Oh, yeah, absolutely. It is funny, just shortly after the reformulation of OxyContin, I was prosecuting a drug case, and the drug dealer had just gotten a batch of the OP drugs in. I mean, they got the new batch, and he was lamenting on the undercover tape how he couldn't figure out how to make it abusable, and he couldn't give them away. So, I mean, I've got this long discussion on tape about all the different methods that he tried, from microwaving them to putting them on a radiator for some period of time. It is amazing what lengths that the criminal mind will go through. One of the really haunting things that we've seen about this issue, and it's been highlighted over and over again this morning, is that it seems to disproportionately affect young people, and it also doesn't seem to have any socioeconomic boundaries. So I'd really like to continue our discussion by posing a couple different scenarios, and I guarantee you that to many of you this will sound very, very familiar. And the reason I'm posing these scenarios is because I've been asked these questions many times myself, and I've been very hard-pressed to give good answers. But the panelists here, I guarantee you, can give good answers to these scenarios. So let me start with the first one. There's a middle-class family in your state where the parents have good jobs, but very little in savings or disposable income. That actually sounds very familiar to me. Very familiar to me, personally. They have a teenager who they have discovered is addicted to prescription opiates. They have also discovered the teenager is stealing from them and other family members to support his or her addiction. They also have a concern that the teenager has started to use heroin. They obviously need to do something. So what do they do? Potentially, what resources do they have at their disposal? Who should they call? And I know, of course, it depends on what state or area they're in, but just, what's the first step? And Rodney, I'd like to start with you if we could.
There are options in Tennessee for this young lady and this family. We have adolescent treatment programs. Sometimes people think they need to leave the state and get services elsewhere. We've got very good programs here in Tennessee. And so I don't know if the person in the scenario, if they have insurance or not. Generally, insurance would pay for treatment. If not, we have federal block grant funding that we can support the treatment in for that family. Sometimes people have a hard time understanding where is the treatment center. We have a 24-hour, 7-day-a-week hotline that is answered by a real live person, and it's called the Tennessee Red Line, and that phone number is 1-800-889-9789, and there you can find where the closest or where the treatment centers are located.
Okay, Kathy, how about West Virginia?
Just to clarify a couple of things for me. When we've traveled the state talking to families, there's a couple misconceptions. They think that treatment is a bed. Doesn't matter whether it's a young person or an older person. They think that everybody's going to go to the Betty Ford Center, there's going to be palm trees, I'm going to ship them off for 30 days, they're going to come back and everybody's going to be well and fine. That is the misnomer about treatment. And so we've had to do some education around treatment availability, because when we was really soliciting this input from our communities, they were saying there's absolutely no treatment. Younger people are using more, pregnant women are using more, but there is absolutely no treatment in this state, and we're sending everybody out of state. Well, there is treatment. There may not be a bed, but what folks don't realize is they need a safe and stable environment, and they can still have intensive outpatient services. Most folks aren't going to assess to the level that they need that inpatient residential treatment. It's just that by the time our families come to realize that they need treatment, there's already sometimes criminal involvement. They're at their wits' end. And they want to get that person out of the environment, and it's not that that's a bad thing. But since we've done a lot of that education, families are really wanting closer to home treatment and care, and because we're really trying to promote more family treatment. And the second piece is, to what I can say to that is, it's really hard for me as I'm the type of person, I've always been a community-based person, and just been in state government 2 years. And with our behavioral health program right now, we are out in the communities. We travel to every region of the state about every other month. I've had 60 community meetings with regional task forces over the last year and a half, and I listen to these stories every single time. And it is the same one. You don't understand, Kathy, I've not had a history of substance abuse in my family anymore. It's not just those people anymore. People I go to church with, people I work with, you don't understand. I don't know about how to get services. So we found that the issue wasn't about not having services, it was about navigation. They'd never been a part of the social service system before. My daughter was president of her senior class, head cheerleader, we don't do drugs in our family, and I went to my pastor and he don't know what to do, you know? I mean, this is every time that I would talk to these families, they've stolen everything from me. Now I have a grandchild, and I'm afraid they're going to hurt the grandchild, so now I'm taking care of the grandchild. And at some point, they have to separate that person from the addiction. I mean, they have to know that that's not their 13-year-old cheerleading little girl, that she needs help. And if someone else stole your mother's wedding rings and someone else stole you blind, you wouldn't keep giving them a key to the house, and you wouldn't keep giving them money, and you wouldn't keep doing all of these things that enables their addiction. So for us, we too have services. We have 13 comprehensive behavioral health centers across the state. They all do outpatient. The majority does intensive outpatient. We don't have a lot of residential facilities. But there's a reason for not having congregate care as much as other folks want to do that. But we have and are changing our system to where there is one single point of entry for youth and families, and also having regional youth centers as well, so that families, there's less stigma in going to these locations, because we also found that our families who'd never been part of the system didn't want to take their kid to the crazy comprehensive behavioral health center, okay? They didn't want to sit in the same waiting room with everyone else. And so that stigma of just getting care was also in the way. So it wasn't just so cut and dried about treatment, and I know that's kind of a long explanation, but it took us a while to figure that out, and maybe that's some of the things that might be going on in your state as well.
Okay, Dan, Operation Unite is obviously on the front lines of this issue in Kentucky. What do you have available there in your neck of the woods, and in particular, what does Operation Unite have going on?
Well, I want to start first by going back to 2000. And I'm not going to say that we as states didn't have a drug problem, but I look at what OxyContin did to our state. We basically woke up one morning and we had an entire generation addicted. It affected our workforces, resources. It was a phenomenon unlike any that I had ever experienced. And we looked around to other states, and it seemed that every state was in the same boat we were. No drug courts, no treatment, very little of anything. So that put us behind the curve. And because of that phenomenon, Operation Unite was started. Stands for Unlawful Narcotics Investigations, Treatment, and Education. We do the three-prong approach. And in Kentucky, I think we're fortunate in that we have two initiatives. We have Recovery Kentucky, which has 8 long-term residential treatment centers that residents of Kentucky can participate in for free. The problem with Recovery Kentucky is you have a 3 to 4 month waiting period, which is quite common. Now, Operation Unite's treatment initiative, we also, like Tennessee, we have a treatment hotline. You can call the hotline at any time. It gives you information on different recovery centers, different places you can go, different resources you can get. The advantage to being a resident of the 5th Congressional District is that we will send you to treatment for free also if you live in the 5th Congressional District. We do make stipulations for juveniles, for pregnant women, and for people that we believe are imminently in danger of death due to drug use. We get those people in the next day. So although we were behind the curve, I think we, in Tennessee and West Virginia and Virginia, I think we're slowly making real progress. And you look at these charts and it shows West Virginia and Kentucky, 1 and 2 in every chart. But I also believe that it's got the attention of our legislators. You know, we passed House Bill 1, we've mandated Casper. We're opening, Recovery Kentucky's opening 2 more centers, which will get them up to 10. I think it's took a long time, but I'm excited in a lot of the things we have going on in Kentucky and in neighboring states. And I know through HIDA and through the U.S. Attorney's Office, we're now collaborating. You know, we came to Charleston a few weeks ago on some different ideas for prevention, and I think as a body of Appalachian states, I think we're going to have to collaborate a whole lot more in the future. I think we're going to have to share resources and share ideas, and it's conferences like this is where we do it. One of the other big things Unite does is we host the National Prescription Drug Abuse Summit. Last year we had right at 1,000 people. This year we're in Atlanta in April, and we bring the CDC, the FDA, many members of Congress, and others together, and we have got to make this a national issue. I know when you watch presidential debates and Senate debates, you never hear a word about this issue. But when you get down to congressional races, and especially county races, this is the only issue people want to talk about. So I think it's our job to collaborate, share resources, and everybody, we've got to make this a frontline issue.
All right. Let's change the scenario just a little bit. Let's assume the same family, but change the person who is addicted to the father. Say he was injured on the job, was prescribed opiates for the injury, got hooked, he's back to work, but his wife has discovered that he's been taking cash advances, using most of their small amount of disposable income to buy more pills to feed his addiction. The wife has confronted him. He admits that he needs help, but he's obviously afraid to lose his job, and he is unsure of what to do. Obviously, it depends on the profession, and let's just assume, you know, again, this is a middle-class family. They likely do have insurance, or probably will have some access to insurance at some point in the future. You know, they work for good companies or the government. Let's just start with that premise. And you know, Sarah, let me start with you on this question in particular.
So my approach to this would be, I guess I would talk about, over the past few years, I've worked with a lot of coal miners, which we know the rate of dependence on opioids and addiction is very high. And what I've been very pleased to see are most of the coal mine companies have employee assistance programs, and these are key. I really applaud the employers that provide these services, because I think they realize in the long run it's more advantageous economically to have, when you have a good worker that's become addicted, recognize it's a disease and you're going to treat the disease. And so they know it's less expensive to treat them, to get them better, and to maintain them in the position than to just fire them and then have to bring someone else in that has to go through the training. So I think if we can promote the employee assistance programs and encourage employees to fight that stigma that's associated with addiction and go forward and say, I have a problem, I need to use this employee assistance program that you have, I think that would be a key answer. And for your scenario, I think if that patient that you mentioned were able to do that, that might be a good resolution.
Let's assume they're a professional as well. I mean, say a medical professional. What efforts have been out there? And I think that most states have these scenarios or programs. Say he's a medical professional. What do you do in that circumstance? Because it's a licensure issue as well.
Yeah, that's a great question to bring up. So fortunately, in all of our states, we have very strong health practitioner monitoring programs. In Virginia, for the pharmacists, have the Virginia Pharmacists Aiding Pharmacists program. They have the health practitioners monitoring program, or you can have the Pharmacist Recovery Network, whatever the name may be. But the nice thing about these programs is that it preserves their license. If they self-disclose or they report to their board that, yes, I have a problem with addiction, and they agree to get treatment, treatment that they pay for, usually themselves, and then agree to do a monitoring agreement with the board for typically 5 years. It's very stringent with urine drug screens and other monitoring, having to attend 12-step programs, counseling, that kind of thing. Preserves their license, we treat the disease, and hopefully get them back working where they need to be.
Another thing that I've had some experience with, I know that in West Virginia, the AFL-CIO, the union organization there, has a very strong program where they look for signs of dependency. They reach out to their membership, and they reach out to their members. If they are addicted, pull them in, get them into treatment, and they have a remarkable rate of success. So, it is critical to look to these particular programs that are in place, because I think businesses are recognizing that it's much more effective, much easier, much more economical to try to get these people into recovery, get them clean, and then they have a light at the end of the tunnel too. I mean, they have something to go back to. And actually, Rodney, let me go to you. Say that this person, while middle class, has health insurance, they don't have at their disposal, their employer hasn't had the foresight to have an EAP or one of those other resources. What are some of the things that you would advise the wife, the husband to do, where to look, what to reach out for?
First of all, shame on the company. They should have an EAP program. There are options for somebody who may be concerned about their job. Some programs offer evening intensive outpatient programs. There's actually several across the state. And I can't say enough about the importance of 12-step meetings. Thank you. Al-Anon, AA and NA are so important in helping a person live a life of recovery. And if that person doesn't, can't get into a treatment center for some reason, go to AA and NA. Matter of fact, go anyway. It's not an alternative to treatment, but it works. It works. Not everybody needs a clinical treatment episode. 12 steps, they've been around for years, they got it right, and they really have good success. I guess that's it.
Kathy, you're down there shaking your head. Do you have something to add?
Yeah, it's probably the most successful approach as far as doing recovery groups. But one of the things we try to do, even though we have same-day access, as folks can go in and get assessed, in that day, there may be a lag time before they can see a doc, because let's face it, we have a workforce shortage. I don't know about all of you guys in your states, but I know I do. I don't have enough licensed folks. I don't have enough psychiatrists. I don't have enough of anything. And I don't look for us to get a flood of them anytime soon. So there may be some lag time before they're seeing a doc, before they're getting into other services. So we immediately try to put them in a group that day. It doesn't matter. So, and if they don't go to get services somewhere, they need to start a group like he said. The second thing is with the employer. There's two groups of folks that I think are such gatekeepers to this issue. One is the personal physician. And I just spent 2 days with docs at our Appalachian Addictions Conference, and we have some great doc champions. And more and more with ACA and all of the changes that we have with the Affordable Care Act, docs are going to continue to be more of the gatekeepers for behavioral health. And so they're going to have to step up, or they're going to have to partner with people who know about addiction and mental health disorders. So for me, that personal relationship with those docs and those docs becoming more in tune to support these individuals, I think is key. The second is that employer. We're getting ready to do workforce roundtables, and initially why I wanted to do these was because I couldn't get any data. And for me, it's a double-edged sword. If I say that, I can't get anybody in the state of West Virginia to pass a drug test, what's that saying about my workforce? So it's tough. So, it was really hard to get that data. So I wanted to pull these folks together, these employers together, to identify the barriers they were having. So we got the top 10 employers from each of the regions. We're bringing them together. We're asking some just focused questions. They'll be anonymous, but it'll be for the region. We'll know for that region what some of the issues are. But the second piece of that, what we found is employers are all over the place. We have some that aren't even designated as drug-free work sites. We have some that are doing EAPs, employee assistance programs, and doing a great job. We have some that it's just they hide their eyes. We have some that you're fired immediately. So there's no good practice consistently going on in our state. While there may be pockets of excellence, it's not consistent. So that full day is going to be really trying to get them to understand what some of these substances are and what is trending in their area, what they can look for, but also what are those barriers, what is an EAP, how to get them started. We're bringing the treatment providers in at the same meeting to try to encourage partnerships so they can do immediate referral. And then the third thing is trying when folks are in recovery to really support them, or even if they're in the regional jail. We've put SBIRT, screening, brief intervention, referral to treatment, in our regional jails. We're getting ready to put DUI programs in our regional jails. The worst thing you can do is when you come out of jail is to not have a driver's license or to not, as a man, to be able to get a job. And then our fine forgiveness, recovery legislation, anything that helps that man stay employed is going to keep him sober. So that he is, that employment and that that physician are both keys for that working man.
Right. And what I'm hearing is intervention points, where identifying places where we can intervene and then get the information to the people who need the information to intervene. And you brought up medical professionals. Oftentimes people will go to their doctors, they'll go to their clergy, but more often than not, I think they do go to their doctors, and unfortunately doctors are by and large ill-prepared in this regard. So education of our doctors is all the more important. And I think Sarah wanted to speak to that issue as well.
Yeah, this has really become, I think, one of my passions, because if you look at the surveys of medical schools across the United States, pharmacy schools, nursing schools, very little education in the didactic curriculum about the appropriate treatment of pain, and certainly very little about the treatment of addiction. And so that is a huge issue. If you look at the statistics, veterinary students get 85 hours on average on how to treat pain. Our medical students get 4. Okay, so there's something wrong there. In Virginia, we don't have mandated continuing education on these issues, whereas the other states, I think all of you do have that, at least 1 or 2 hours a year, and so that's been a real struggle. With OneCare, the organization that I chair, which is a collaborative of many different substance abuse coalitions, went against the Medical Society for many, many years because we wanted that 1 hour at least of education, and it's tough because they're very, very powerful lobbying. So what we've ended up doing is partnering with them and to provide the education, and so we're starting our second year, and we're, this Friday at the University of Virginia, we will finally have reached our 1,000th prescriber or dispenser. So I think that's pretty good for 1 year. The problem is we're not getting the people that we know are the very bad prescribers, or the ones that will dispense anything to these. And so that's an issue that we really still have to work on in Virginia. It's how do we get the people that we know need that education to be there?
Another intervention point is with kids, and unfortunately with very young kids. I mean, I'm the father of an 11-year-old and a 9-year-old, and I know that Operation Unite, it was part of a study that showed that the first illicit use of narcotics is and can be at age 11. So it's so critical to reach kids while we still have them, while there's still a captive audience, and I've more and more been reaching out to middle school kids because they're old enough to get it, but still young enough to listen to somebody, with authority. And I know that Operation Unite, that's a very key portion of its mission. And I wanted Dan to talk a little bit about it, what they're doing in terms of outreach.
We get about 1,200 calls a month to the treatment referral hotline, and one of the questions we ask, as Booth said, is age of first use. And I guess one of the most troubling fact I learned through that voucher system was the average age of first use is age 11. Now, people like myself and Tommy Lovin, other old people, first time I was offered dope, I was a junior in college. Now it's 7, 8, 9-year-old kids experimenting with drugs. So we have basically robbed our children of their childhood. People ask at what age do we start talking to our kids about drugs? And my answer is just as soon as they can comprehend, because it is in our grade schools, it for sure is in our middle schools, and it is all over our high schools. So one of the things we did at Unite is through the education team is prevention in schools. We formed anti-drug Unite clubs. Our newest effort, and we took it to Charleston, is a 36-foot drug education trailer. And what we want to do is get the kids in the trailer, show them clips, and then ask them questions and find out what kids know. We have long thought we knew what kids know, but we're bad wrong. And now you take the influx of social media and so many other things where they can share what they find out, it's just making it tougher and tougher. And we talked about kids. We have several counties in East Kentucky that over 50% of the children are being raised by someone other than their parents. And it's because of the drug problem. And we talked, which was mentioned earlier, one of the phenomenons that has arisen through our problem is the faith-based community. We have Celebrate Recovery in every community. There's not a church in any town that you can't get help somewhere. And I think everybody's starting to pitch in, from every different discipline. One of the major things we have going on in Kentucky, and a couple of the representatives are here, we sued Purdue Pharma in Pike County, Kentucky. We think, especially after pleading guilty on their civil charge, we think that they should be held responsible for a lot of the overdose deaths in our region. And we have, in Kentucky, we reached out to the medical professions and we mandated training. Prescribers now have to have addiction training. The only group we've been unable to get to the table to try to work out solutions is the pharmaceutical industry. And I think we all know why. It's a profit-driven organization who's making a whole lot of money. And I think it's time for them to come to the table.
one thing that's been talked about a lot over today has been the medically assisted treatment. And I was talking to Kathy just before we started the panel, and do we have medically assisted treatment, meaning the Suboxone treatment in federal facilities, in BOP facilities? I don't know. I'm going to check on that. But this is something that I've wanted to learn more about. And one thing that I've heard over and over again today has been, especially with Suboxone, it works, but it can't just be, show up at the clinic, get your pill, and walk back out the door. It has to be a part of something larger. And Sarah, if you could speak to that briefly again, too.
So, when you're driving down the interstate and you see signs that said, do you need Suboxone, call 423 and a number, you start thinking, what's going on with this? And so I called that number. I don't need Suboxone, but I wanted to see what they'd say. And the truth of the matter is, we have a lot of pill mills that are dispensing buprenorphine, whether it be the Subutex or Suboxone, and that's a huge issue. It's a wonderful drug in the right circumstances, but it's only a small part of the tools in your big toolbox. It is what you use to help decrease the cravings, to help the patients do what's really the hard work, doing the counseling, understanding why they got addicted to begin with, doing the work to become productive members of society again. And so it's a tool that's meant to be used appropriately, but these clinics that let the patients come in and they're giving them 4 strips a day of 32 milligrams and not running prescription monitoring programs and not doing urine drug screens and charging astronomical amounts of cash, that's a pill mill. And so I really think we need to have a higher standard for what is an appropriate treatment program that you can do outpatient, because we know they can be extremely successful if they're done the appropriate way with mandated counseling and doing group therapy and having an addiction counselor on site and doing a urine drug screen every visit and being there for the support for the patients. But I find it to be a huge challenge because we know it's all on the streets now. We're not getting patients that come in for treatment that have to be induced. They've already induced themselves on the street with, they're treating themselves out there. So I think that's something we need to talk about.
Either Rodney or Kathy, one of the other drugs that's been talked about today that has been identified as very useful is Vivitrol. But the problem with Vivitrol, from what I understand, is that it's pretty daggone expensive. Is there coverage for that? And is it general, or is there varying levels of coverage for that, by insurance? And just what is its availability? And maybe I'm not asking the right question or not a broad enough question, but is that a realistic possibility? Is that a realistic avenue for treatment for our father in our scenario?
Different states vary on whether it's covered by Medicaid as far as Vivitrol and Suboxone. We prefer Suboxone. We do a lot of Suboxone work in our state. But Vivitrol, a lot of folks felt like it would be good for the incarcerated population because it's just one shot. Other people think that it's a good method because it's a change from what they're normally doing. It's a change in behavior from taking a pill, but so is the film when you're using Suboxone. So, it's changing up that normal behavior that you're used to. So there's a lot of things to look at in prescribing. The doc conference that I was at Friday and Saturday, jury's still out with them. A lot of them haven't used it. Some have, and I think maybe Dr. Walker or some of the folks that are part of the VA system. I think that some of them have used Vivitrol, but I think it runs case by case with regard to coverage as far as Medicaid goes, particularly. The one thing I wanted to say with regard to what you were saying with regard to prevention, and I think somebody said it earlier today, is our communities are kind of, we do evidence-based programming in our schools with our very young kids. And we've done that more for the parents than for the kids, I'll just be real honest. And because it is more, it's smaller. Now, you know, when you're doing these universal prevention programs, that's what they want us to do because it reaches more. But what we have found with that environment, with environmental strategies, it really improves just the communities and the norms in the communities, and that's what we've got to focus on and do. Because, again, we've decreased prescription drug abuse in West Virginia for the first time since 2006, but heroin's up, meth's up, you know. So, again, it's that flavor of the day. Now, personally, I think some of those folks aren't going to divert to a needle. I think personally there's some folks that just aren't going to use some substances if they've been taking what they think is more legal and more palatable because it's a prescription drug, especially the young kids. But I really think that we really have to focus on that norms change, that this is not business as usual. And I know that's where we're focusing a lot of our prevention efforts. And particularly with communities, and are going to be doing that more over the next year, really focusing on that aspect.
Well, and that's good to point out. I do want this panel to convey that good things are happening. I mean, there's a lot of people working very hard on this issue, and that there is hope. I was talking to our next speaker just before this program, and he was telling me he'd watched this movie called Oceana, which revolves around life in Oceana, West Virginia, obviously in my district, and it's painted as the epicenter for all things evil, and it's just the most horrible place on earth. And Dr. Lloyd said the most troubling part of that movie to him was that there's this overwhelming sense of hopelessness. That's what it really conveyed. And I hadn't put my finger on just why it troubled me so bad, but he's absolutely right. And what we've got to continue to focus on is that there is hope, and that this is a problem that can be tackled. And the purpose of this summit and to get the region together is to talk about things that are working in our respective states, and frankly, to steal them from each other, so that we can duplicate what's working, we can do away with what's not, and focus the limited resources that we have on this most critical of issues. So at this point, I'd really like to open it up for more discussion from the folks in the audience.
Sarah, I do appreciate what you said and what's been said about medication-assisted treatment. It takes somebody, when you put them on a drug and you don't change anything in their life, and now you have them on a drug, at least they're not sticking needles in their arm, but you put them back in the same crappy place that they came from and they were using to start with. And particularly females who have had significant trauma in our area. Incest is not an uncommon thing. Farming kids out for sex is not an uncommon thing, and that is really deep stuff that you're not going to address in a 28-day treatment program. So I want to know how we are able to get these folks the treatment that they will need over the long term. 28-day treatment program, does anybody know where the 28 days came from? Insurance companies.
Insurance.
Pay for it, so, I want them to leave me, most of the time, they usually know what's right. And, we're gonna have to open our minds here a little bit, because that's a longer process. And if you're able to keep people off drugs, and let it move through that process, then I'm fine with any with it. The reason I'm sitting here, to be honest with you, is because I have the money to afford top quality treatment. And I've got a little bit of an issue with that being the second. So, do you have any ideas about how to do that? I mean, I know you and your husband both have done this for a long time. How do we do that with a population of people that don't have the money to do it?
That's a really tough dilemma, and I think with what Project Unite is doing, where they actually pay for the treatment, is phenomenal, because people are actually getting access to longer-term treatment, maybe longer than 30 days. We know for most people it takes a lot longer than that, and when you get out, you need to have the outpatient treatment. But I think a lot of people underestimate the power of intensive outpatient treatment, even going to evening programs. In Virginia, Medicaid does pay for a lot of those treatments. They don't pay for inpatient treatment at all, but they will pay for the counseling that is needed. So I think having an addiction counselor that can really get to the root of those reasons you're talking about with the abuse, why they started using the drugs to begin with, and then how are they going to change what they're doing now so that when they get into recovery, they don't relapse and do that. So I think just looking at the different examples around, with Kentucky, with Unite, and West Virginia and Tennessee, what they're doing, that's what we have to go for. We can't depend on the insurance companies and other things. We have to be more innovative in getting people into the 12-step programs that we talk about. I mean, the power of those we really just often don't recognize, I think, enough.
And I just wanted to say, we've redirected and changed a lot of our funding, and the reason we've done that is for that reason alone. We're doing a lot of peer supports, recovery coaching. We have a lot of recovery residences that we didn't in the past, and it's just for that reason. You couple particularly women's programming that do much better in the evening, because from doctor's appointments, kids' things that are going on during the day, it's got to be evening. So having safe and supportive housing that's much more affordable than building treatment centers, and then having that intensive, outpatient services, or those outpatient services coupled with recovery coaches who've been there, done that. I respect you, support you for long term is what we're kind of betting the farm on. I mean, honestly. And so a lot of our funding is being redirected in those areas. And that's one of the reasons.
Yes, sir.
Just wanted to comment on, this is not panel on reducing the demand and getting back to some of the original sources of demand as a pain management provider. There was a day when they used to say, pain is what the patient says, there is no limit. We gave the patient it's a 6 vital sign. I mean, we were hammered as early as 6 or 7 years ago that we weren't treating patients enough, we weren't giving them enough drugs, and doctors were getting sued for under-treating pain. So, it's darned if you do and darned if you don't. So I think that mentality contributed a little bit to it, made it available. And so now, as you mentioned, the reformulation of OxyContin and Opana, it's amazing how many patients came in and said they were allergic to that new stuff. All allergic to that new formulation, they had to be put on the generic Opana. But the insurance companies don't pay for that fancy stuff. And the people at greatest risk, to be quite frank, the Medicaid population, the Medicare under 65 population are the ones that want the early refills, they're losing their scripts, quote unquote, stealing, etc. I can't give them, tamper-resistant Opana or OxyContin. I have to give them MS-Contin, or worse yet, for short-acting opiate. So the insurance companies also contribute by not covering the good stuff, quote unquote, the tamper-resistant. And the federal and state programs certainly don't cover it. So you can always revert to the argument that nobody has shown that any of these opiates helps anybody in the long term with regard to their pain, so maybe we should give nobody anything. And that's what some people say. I'm somewhere in between. But, again, darts are thrown at us a lot, but our tool bag is not as big as Ms. Mullen would have us believe, in my opinion.
Well, we are, we have about 2 more minutes left in a very short panel on reducing the demand. And if we've learned anything today and through this fight is that there's a lot more issues than we could even cover. One of the things that we did talk about in preparation for this panel was that culture at hospitals through insurance companies, the patient satisfaction surveys, and driving, and hospitals driving pay and evaluation of doctors based on patient evaluations. That's going to, in turn, probably drive, what you identified is more prescribing, so that the patient is happy when they leave. We did talk about that. But I would encourage you, and I would encourage all of you. What we want to do is at the end of this, put together a report based on what we've talked about today, what you all want to share with us, and issue some recommendations based on that in pretty short order, because I know our legislative session in West Virginia is coming up in the first part of next year. I don't know about the legislative terms of the other states, but there are some things that should be on those legislative agendas. So I want to thank you all very much. I want to turn it over to the good doctor, and I want to thank the panelists, and I hope that you will give them a big round of applause.